I'm Jennifer Fang, Neonatologist at Mayo Clinic in Rochester, Minnesota, USA. Thank you to the conference organizers for inviting me to be a part of this year's 7th Annual International Pediatric Medical Congress. I will be presenting on the preoperative assessment and management of neonates with cardiac disease, focusing on those neonates that have impaired systemic or pulmonary blood flow. So over the next 25 or 30 minutes, I will be reviewing the preoperative physiology, assessment and management of neonates with both right-sided obstructive lesions and those neonates with left-sided obstructive lesions. So I thought I would start with an overview. So congenital heart disease is the most common major congenital anomaly. Anywhere from 8 to 10 neonates will have congenital heart disease per 1,000 births. When we talk about critical congenital heart disease, this includes malformations that are dependent on ductal blood flow to supply either the systemic or pulmonary circulation. So critical congenital heart disease is a subset of congenital heart disease. And when we think about how neonates present when they have congenital heart disease, there's a few different signs and symptoms that we'll notice. So first is cyanosis, and this can be due to either inadequate pulmonary blood flow or the mixing of deoxygenated and oxygenated blood. Neonates may have respiratory distress due to excessive pulmonary blood flow or obstruction of pulmonary venous return. Neonates who have obstruction to systemic blood flow or those left-sided lesions may present with poor perfusion. It's very important to know that prostaglandin is life-saving for neonates who have ductal-dependent heart defects. So we need to make sure that prostaglandin is started as soon as possible. PGE is a very safe drug. It does have side effects that we need to be aware of, including apnea, fever, and irritability. Generally speaking, the dose of prostaglandin will be anywhere from 0.025 to 0.1 mics per kilo per minute. If this is a newborn with known congenital heart disease and you're starting to care for them in the delivery room, you should be able to start at a lower dose because that PDA is already open and you can use a lower dose to keep it open. Conversely, if this is a baby who's a couple of days old presenting with suspected CCHD, then you'll need to start with that higher dose to reopen the PDA. So let's start with a clinical case. This is a full-term neonate who's cyanotic, O2 saturation 75 to 85%. When you examine the baby, you note a systolic ejection murmur that's been present since birth. And you obtain a chest x-ray and find that there's reduced pulmonary vascular markings. So what's going on with this neonate? So this is a baby who has a right-sided obstructive lesion, such as pulmonary stenosis. The baby's cyanotic due to decreased pulmonary blood flow, which is why those vascular markings are difficult to see on x-ray. And you also have that ejection murmur due to obstructed flow across the pulmonary valve. So again, right-sided obstructive lesions are those that have impaired pulmonary blood flow, and it includes lesions such as tetralogy of Fallot, critical pulmonary stenosis or pulmonary atresia, and tricuspid atresia. So let's review the physiology of these right-sided obstructive lesions. So generally speaking, the degree of obstruction is what's going to determine the severity of the disease. So the more severe the obstruction, the greater the degree of cyanosis and the greater the neonate's pulmonary blood flow is dependent on the PDA. Now, when we think about flow across the ASD in these neonates, because of the right-sided obstruction, flow across the ASD will go from right to left. And there's going to be mixing then of that deoxygenated blood with the oxygenated blood causing cyanosis. Now, because there's severe obstruction, pulmonary blood flow is going to be dependent on flow across the PDA. So flow across the PDA will be from left to right so that the systemic blood flow is actually supplying the pulmonary blood flow through that PDA. Now, because of the intracardiac mixing, the O2 saturations in these babies will be low and they will be equal both pre and postductally. Clinical features of our neonates with right-sided lesions are like those presented in the clinical vignette. So these babies will be cyanotic. They may have a murmur, such as with pulmonary stenosis or tetralogy of Fallot. And you may notice either a single S1, so if this is a tricuspid atresia, or a single S2 in the case of pulmonary atresia. And if the PDA closes in these babies who have ductal-dependent pulmonary blood flow, then these neonates will become profoundly cyanotic, tachypnic, and acidotic. So if you have a baby presenting, what are you going to do as part of your assessment? So first, simple way to assess the baby would be imaging with a chest X-ray. So again, because there's decreased pulmonary blood flow, the chest X-ray is going to show dark lung fields. There's going to be decreased pulmonary vascular markings. So when you look at this baby who's cyanotic and not oxygenating, instead of being concerned about something, let's say like RDS or meconium aspiration, where those lung fields may have patchy or diffuse infiltrates, these lung fields will be very dark and appear clear. You're going to do continuous O2 saturation monitoring, monitor arterial blood gases, as well as lactate. And this will be important because you want to make sure this neonate has balanced pulmonary and systemic flow. So you want to make sure your QP and QS are about equal. Your target saturations are going to be 75 to 85%, again, because of that mixing. And so saturations in this range with a normal lactate will indicate balanced pulmonary and systemic blood flow. Conversely, if you start having a baby with high saturations, this is going to indicate pulmonary overcirculation. Now, this could happen if there's excessive flow from left to right across the PDA. So for example, as pulmonary vascular resistance drops, or if you're perhaps providing too much supplemental oxygen, causing increasing pulmonary vascular relaxation, you could have excessive left to right shunt and then pulmonary overcirculation, which you'll know because your saturations are too high. If you see saturations less than 70%, as well as a rising lactate, this is going to be very concerning that pulmonary blood flow is insufficient and you're having hypoxemia. As might be expected, echocardiogram is diagnostic. So the echocardiogram will give you the diagnosis of the congenital heart disease and will be able to provide information as well on severity and evaluate features that are going to be needed for subsequent management decisions, such as surgical planning. Other things that we think about in our babies with CCHD is doing a genetic evaluation. So what might be available to you, for example, a chromosomal microarray. So for example, in tetralogy of Fallot, you may be looking for DeGeorge, Charge, or trisomy 21. Pulmonary stenosis can be seen in infants with Noonan. So how about management of these neonates with right-sided obstructive lesions? So first and foremost, again, is initiation of PGE, that you need to get that going to ensure continued pulmonary perfusion. Targeting appropriate O2 saturations between 75 and 80%. You don't want these babies too high sat because that, again, can lead to that pulmonary overcirculation, which is undesirable. If with PGE, you aren't able to increase pulmonary blood flow sufficiently, the baby is still too hypoxic, then you may need to decrease oxygen demand and proceed with intubation, mechanical ventilation, and sedation and/or paralysis. You may also need to support cardiac function by correcting any acidosis, for example, with acetate fluids, and providing ionotropic support. Okay, so let's move on to our next clinical case. So now you have a 3-day-old infant who presents to you with poor feeding. The neonate is ill appearing with poor perfusion. You notice systolic ejection murmur that radiates to the back, and femoral pulses are decreased. So again, this neonate is showing us signs of poor systemic perfusion. Clearly on your differential might be other things, such as sepsis or metabolic disorders. But when you also have decreased femoral pulses and that murmur, that may point you towards a cardiac etiology. So again, now we're shifting gears to these left-sided obstructive lesions where we have impaired systemic blood flow. So examples of this will be coarctation of the aorta, which is illustrated here, interrupted aortic arch, critical aortic stenosis or aortic valve atresia, and hypoplastic left heart syndrome. So let's review the physiology for these left-sided obstructive lesions. So again, the degree of obstruction will determine the disease severity. And in this case, the more severe the obstruction, the worse the infant will be with respect to hypotension, shock, acidosis, and poor perfusion. Now, in this situation, because there is obstruction to flow on the left side, flow across the ASD will actually be left to right because of that left-sided obstruction. And then with severe obstruction, in order to provide blood flow to the body, flow across the PDA will be from right to left. And so this is where we get that post-ductal desaturation or hypoxia. So the PDA is now supplying the systemic blood flow. Now, when we think about desaturation in these infants and looking at pre and post-ductal saturations, whether or not pre and post-ductal saturation are equal will depend on the type of lesion. So in lesions where there is intracardiac mixing, or where the PDA is supplying flow to both the proximal and distal portion of the aorta, the pre and post-ductal saturations will be low and equal in lesions such as critical aortic stenosis and hypoplastic left heart. Where there is a lesion such as coarctation or interrupted aortic arch, and the PDA is supplying blood flow only to the distal arch, then actually the preductal saturation may be normal because that's being supplied from the aorta with fully oxygenated blood, but the postductal saturation will be low. So the preductal will be greater than the postductal saturation, and you'll see that differential. So let's move on to assessment of these neonates. So clinical features. This neonate may have a murmur, as we heard in our clinical vignette. It could be due to the coarctation, could be due to something like aortic stenosis. Babies might have a single S2. So if you have aortic atresia, then you may only hear that single second heart sound. And the postductal hypoxemia is going to be, again, due to that right to left flow across the PDA, as I mentioned in the previous slide. Now, PDA closure in these infants will lead to hypotension, weak distal pulses, poor perfusion, tachypnea, and acidosis, because now the neonate has lost the source of their systemic blood flow. How are we going to assess the neonate where we suspect a left-sided obstructive lesion? First, again, you may do an X-ray. Now, chest X-ray in these neonates may be normal, or you actually might see increased pulmonary vascular markings, and that may be due to pulmonary overcirculation, or it could be due to kind of pulmonary venous congestion due to that left-sided obstruction. Again, you'll be doing continuous O2 saturation monitoring, as well as checking your ABG, as well as your lactate, because again, this is about how do we balance the systemic and pulmonary blood flow and perfusion. So again, expecting O2 saturations to be kind of at 75 to 80% with the normal lactate will indicate that we're having balanced perfusion between our lungs and the body. If a neonate has O2 saturation greater than 90% and a rising lactate, this is going to be concerning that we're getting too much blood flow to the lungs and not enough blood flow to the body, that we're having systemic underperfusion. O2 saturation less than 70 in these neonates actually may indicate late stage cardiovascular collapse. If the baby is so far into their disease that now we're seeing severe hypoxemia. Again, these babies need an echocardiogram as soon as possible because that is diagnostic. It will give you the diagnosis as well as assess the severity of the underlying disease, and again, evaluate those features that will be needed for planning, such as making the surgical plan for the neonate. Again, there's a role for genetic evaluation in these babies. Infants who present with coarctation, especially female infants, may be evaluated for Turner syndrome. Interrupted aortic arch is associated with DeGeorge syndrome or velocardiofacial syndrome or 22q11 deletion. And if you find supravalvular aortic stenosis, that's associated with Williams syndrome. So treatment principles for the management of neonates with left-sided obstructive disease, again, critical to treatment is initiating prostaglandin because we need to provide a stable systemic blood flow source. Goal O2 saturation should be that 75 to 85%. These neonates may need support of their cardiac function. They may need volume resuscitation if they're demonstrating poor perfusion, lactic acidosis. You'll need to correct that lactic acidosis either with fluids or perhaps with acetate. And these babies may need ionotropic support for that left ventricle. You know, in our babies who have right-sided lesions, that right ventricle is been well conditioned in utero, you know, to be really pumping against higher pressure. However, the LV is not. So that LV is more prone to failure and may need ionotropic support. Again, if you're not reaching the goals of care with just prostaglandin, babies may require intubation and mechanical ventilation, and you may need to decrease that oxygen demand further with sedation and paralysis. These neonates may need a higher hematocrit to really promote and increase oxygen carrying capacity and oxygen delivery to the tissues. And if you're having pulmonary overcirculation, there may be a role for diuretics. So as we move forward here over the next, 5 to 10 minutes, I wanted to give just, again, that kind of higher level general overview about management principles. So when you're managing a neonate and you're really focused on optimizing oxygen delivery, we want to think about that in two ways that we can approach this. One is to improve oxygen content of the blood, and the second will be to promote oxygen blood flow. So if we first look at oxygen content as a way to promote oxygen delivery, we know that oxygen content is driven by hemoglobin as well as the saturation and then our constants. So these babies where you're really optimizing oxygen delivery may benefit by red blood cell transfusion to increase that hemoglobin. On the other side of this equation is thinking about how do we promote oxygen delivery through promoting oxygen blood flow. So this is where we really want to augment that systemic blood flow, or our QS. And our systemic blood flow is impacted both by stroke volume and heart rate. So we're going to think about promoting systemic blood flow by optimizing stroke volume, which we can do in two ways. So we can either increase the preload, and this is where we may do things like giving the normal saline bolus and providing extra volume, or increasing stroke volume by improving contractility. And this is where we may use our ionotropes, such as dopamine or dobutamine. Now, in addition to optimizing oxygen delivery, as I mentioned earlier, the other thing we can do is decrease oxygen demand. So we can also work kind of from that approach and try to limit oxygen consumption by either ventilating that baby and also offering sedation and paralysis, so there's less tissue demand. What about ways to limit pulmonary blood flow? So as we think about pulmonary blood flow and balancing QP, QS, as I've been discussing earlier, we do have a bit of a guide, even clinically, with how well we're doing with that. So if we think about oxygen saturations, the oxygen saturation coming from the lungs, from the pulmonary veins is going to be 100%, whereas our mixed venous saturation may be 50%. So when we look at our O2 saturations, we can use that to estimate our QPQS. So again, we're targeting, and our goal is that saturation of 75% to 85%, because we know that approximates a 1-to-1 well-balanced QPQS. However, as our saturations increase, we start to have mismatch of QPQS with excessive pulmonary blood flow, to the point where, as if we're seeing saturations of 90% or greater, you can see that's about a 4-to-1 pulmonary to systemic blood flow. So this is just kind of a guide that you can use clinically to get a sense of how well you're doing balancing pulmonary and systemic blood flow. So when we find ourselves in situations where we have excessive blood flow, where our saturations are in the 90s, what can we do to reduce that? So first of all, we can think about, okay, we have excessive blood flow. This may be causing pulmonary edema, and that we can treat with our diuretics, for example, furosemide. In addition, we can think about ways to increase our pulmonary vascular resistance to decrease pulmonary blood flow. And we have a few different tools that we can use to do that. So first is we can try to promote a respiratory acidosis. So when these neonates are intubated and ventilated, we may want to take control of their respiratory drive and use a lower ventilator rate. Now, in order to do this, we may need to heavily sedate or even paralyze the neonate, and then use a lower ventilatory rate so that we have a higher PCO2 and a bit of a lower pH to try to increase our pulmonary vascular resistance and decrease pulmonary blood flow. We can use higher end expiratory pressures on the ventilator. So using PEEPs of anywhere from 6 to 8 to really increase that pulmonary vascular resistance. If needed, we can also use subambient oxygen. Generally, we'll use many other strategies first before we move on with subambient oxygen, and we generally won't go lower than 16% FiO2 in our neonates, just due to concerns for cerebral perfusion and cerebral oxygen delivery. But we can use subambient oxygen to, again, try to further increase PVR. Lastly, we can use that strategy of trying to increase blood viscosity by targeting a higher hematocrit, again, which gives us an opportunity to use blood transfusion if needed. So with that, I hope this was a helpful review on the physiology, assessment, and management of neonates with right and left-sided obstructive lesions. So again, first and foremost is the importance of prostaglandin, and that if we're suspecting a ductal-dependent lesion, we need to initiate this as soon as possible. These babies also need an echocardiogram as soon as possible, because this is diagnostic and will help guide our management subsequently. In addition to PGE, these neonates may need other treatments to help optimize oxygen delivery or balance pulmonary and systemic perfusion, and this may include things like mechanical ventilation, sedation or paralysis, ionotropic support, and blood transfusion. I've included a few references here that include a couple of textbooks and a few review articles that may be helpful if you want to read more and learn more. Thank you for your attention. I apologize that I'm unavailable for the live Q&A due to the timing of the conference and the time difference, but please don't hesitate to reach out via email if you have any questions. My email is here. It's fang.jennifer@mayo.edu. Thank you.
Thank you very much.